Okay, so today I'm going to be doing the physical exam of head, ears, eyes, nose, and throat. So I'm going to be starting with the head and the face. I'm going to be inspecting it, making sure that everything's symmetrical, that it's intact, there's no lesions, no swelling. I'm going to also be taking a look at the scalp, going through the hair, making sure there's no pieces of hair missing, any alopecia, any swelling, any lesions in the skull. Everything looks intact. Next, I'm going to be moving down to the eyes. I'm going to start by checking the central vision. Central vision is checked with the Snellen test. I would hold the card about 18 inches away from the patient. I'm going to ask you to please cover one of your eyes with your hand, and you're going to read the lowest line for me.
LTFPH.
Okay, so that is the last line. That's a 20/20 vision on the left eye. Now you're going to cover your left eye with your hand and read the lowest line again.
LTFPH.
So that's again a 20/20 vision on the right eye. She does wear glasses, so we would ask the patient to keep the glasses on, that way to make sure that the glasses are actually working, and she's able to have a good vision with them. Next, I'm going to be doing the visual field, so I'm going to be checking the peripheral vision of the patient. I'm going to ask the patient to please cover one of your eyes, either the right or left. Perfect. I'm going to be holding up my hand. It's either going to be with the number 1, 2, or 5. You're going to stay looking at me as I hold up my hand. You're going to tell me what number I'm going to be putting up, okay? All right, ready?
1, 2, 5, 2.
Okay, so that's intact peripheral vision on the left. Now you're going to cover your left eye, and we're going to do the same thing again.
2, 2, 5, 2.
Okay, so that's intact peripheral vision on the right here as well. Next, I am going to be doing the Hirschberg test. This is for me to shine a light onto the patient, and I'm going to be checking to see that the light is actually, that the reflection of the light is equal on both sides. It is being reflected evenly on both eyes, which it is. The light is in the same position on both eyes. Then I'm going to do the cover and uncover test. This is where I will ask the patient to please stay looking at me. I'm going to be covering one of the eyes. Then I'm going to remove the card. I'm going to look for any nystagmus. If the patient does have nystagmus, when I remove the card, then the eye will be going from side to side. The covered eye will go to side. I'm going to do the same thing with the other eye. Cover it. Then I move away the card. For her, the vision, both eyes have stayed on me, regardless of the card being present or not in front of her eye. Next, I'm going to be doing the 6 cranial fields. This is where I would ask you to please follow my finger without moving your head as I point to 6 pointers from 3 on either side, okay? So you're going to follow my finger just without moving your head. Okay. Okay. Side. Okay. Now that I'm in the middle, I'm also going to check to ask her to stay looking at my finger. I'm going to move closer to her nose. I'm looking for her eyes to converge inward, but the pupils to also constrict at the same time. Next, if you can please take off your glasses, I am going to be inspecting and palpating the eye structures. I'm going to see that the eyes are even, that they're equal, that there's no redness, swelling, any sort of lesions on the eyes. I'm going to ask her to please look down, look to the other side. Okay, good. I'm going to be going up, look to down, look to the other side, making sure that the sclera, and I'm also, that's white, and I'm looking that the conjunctiva is pink and moist. Okay, now I'm going to be looking at the cornea. For the cornea, I'm going to see that it's clear, there's no clouding, no lesions. I'm also going to look for the cornea. I could also do a corneal reflex. This is mostly when the patients are comatose, to see if they have some sort of a reflex. So I would get a Q-tip, or I would get a cotton ball, and I would come and put it to the eye and see if they actually have a reflex of closing their eye. Because she's conscious, I wouldn't be doing it on her today. I'm gonna take my pen light, and I'm going to see if the pupil size and the reflection is even on both sides. So I'm gonna grab the pen light. I'm gonna make sure that the pupil's constricting. As I'm doing it on the left eye, I'm also checking that the right eye's pupil is constricting. This is to see that the pupil has both direct and consensual pupillary reaction. So that means that as I shine it on the eye, the eye that's being shined is constricting, so that's the direct one, but also the one on the opposite side, so the left eye is also constricting. That's the consensual pupillary reaction. I'm going to look at the iris to see if there's any lesions, any brown spots, so that's the white portion of the eye. There's no redness, no lesions at all. Okay, I can shine the light from the side, make sure that there's no shadowing at all, and she doesn't have any shadowing. Next, I'm going to be inspecting the ears. For the ears, I will look to see if she has any sort of lesions, if she has any bulging, any exudates coming from it. I will look behind the ear as well. I would come and I will palpate the tragus. Do you have any pain?
No.
I will pull up the pinna to see if she has any pain. Any pain?
No.
Okay, so there's no pain. I will do the same thing on the opposite side. I'm going to see if there's any bulging, any redness, any swelling. There's nothing. Do you feel any pain?
No.
Okay, do you feel any pain?
No.
Okay. I can also at this point do the whisper test. So this is when I ask the patient to, I'm going to be covering one of the ears, and I'm going to be at about arm's length, and I'm going to whisper a word, and I will ask the patient to please repeat it. So I'm covering her opposite ear. I'm going to whisper a word to you.
Car.
Okay, and then I'm going to be doing it on the opposite side as well.
Car.
Okay. So as for the whisper test, I whispered a word on both ears. She heard, and she was able to listen despite it being a whisper. Next, I'm going to be doing the rind test. I have my tuning fork for the rind test. I will strike the tuning fork, and I would ask the patient, can you hear this?
Yes.
Okay. Next, I will take the tuning fork, and I will place it behind her ear where the mastery process. You're going to still hear the ringing. When you stop hearing the ringing, let me know.
No.
Okay. Now can you still hear it?
Yeah.
Okay. So I'm going to do the same thing on the opposite side. Strike the tuning fork. Can you hear this?
Yes.
Okay. Then I'm going to put the tuning fork to the mastery process, which is behind the ear. Let me know when you can no longer hear it.
No.
Okay. Can you hear this?
Yes.
Okay. So this is checking for air conduction, and it's equal on both sides. She doesn't have any hearing loss in that sense. I can also do the Weber test. The Weber test, I strike the tuning fork, and I place the fork now, instead of on the ears, I'll put it in the middle of her forehead. Can you hear the ringing evenly on both sides?
Yes.
Okay, so that means that she has equal hearing on both ears, and there's no lateralization, meaning that there's no greater hearing on one side compared to the other. Next, I will inspect the nose. I will look to make sure there's no lesions, no swelling, no exudate, no drainage coming from the nose. I would ask to please check. I can ask for patency. So for here, if you could please close one of your nostrils. Inhale. Okay. Now do the same thing with the opposite one. Inhale. Okay. Can you breathe evenly on both sides?
Yes.
Okay. So that means that the nasal passage has patency to it. Then I'm going to ask the patient to please tilt your head back. Okay. I'm going to make sure that the nares are even. Next, I'm going to grab the nose, the tip of the nose. I'm going to bring it up. I'm going to look to see if there's any swelling, drainage. I can also take the otoscope, and I could look inside. I will look at the turbinates to see that there's no swelling, no lesions, and it's intact. Okay, and I can, for the nose, I will also be palpating it to see if you have any pain.
No.
Okay, beautiful. With the otoscope, in regards to the ears, I would also do the same thing. I would go in, and I would I would go to the tragus, put it against it. I would bring up the pinna, and I would look inside the ear, see if there's any drainage, swelling, any exudate at all. And there's nothing on this side. So when I put the otoscope in, I will put it against the tragus, bring it up. I'll bring up the pinna, and I will look inside the ear to see that there is no drainage, swelling, it's intact. Beautiful. Okay. For the sinuses, I will do palpation first. So that's when I'm gonna grab my thumbs and I'm gonna press them down. I'm checking the frontal sinuses. Do you feel any pain?
No.
Okay, then I'm checking the sinuses here. Do you feel any pain?
No.
Okay. Next, I will percuss. So for percussion, I lightly tap on the patient. Do you feel any pain?
No.
Okay, do you feel any pain?
No.
Okay. There's no pain or tenderness there. Next, I'm doing the mouth and throat inspection. I will ask the patient to please tilt your head back a little bit and open your mouth. I will shine the light inside her mouth. Open your mouth wide. Beautiful. And we'll check for any redness, swelling, lesions, any sort of abnormality. I could also put some gloves on and I could go inside and touch the patient's mouth to check for the glands and to see if there's any sort of abnormality, any openings that shouldn't be there, any tenderness as I palpate along. I will look at the lips, the buccal mucosa to make sure that everything's pink and moist. I will look at the throat to see if there's any swelling or anything in the back of the throat. I am redoing the cranial nerves for the mouth and throat. So to assess cranial nerve number 9 and 10, I would assess the patient for swallowing, a gag reflex, the quality of the voice. I would observe the palate elevation, see if there's any taste abnormalities and sensation. So please open your mouth. And then I would, with a pen light, I would look at the palate. For taste, you can eat the chip. Do you taste it? Is it what flavor is it? Is it salty or sweet? Okay. And then I would give him some water to see how his gag reflex is. And for the swallowing. Then to assess for cranial nerve number 12, I would look for tongue atrophy. So I'll ask the patient to please, you're going to, your tongue inside your mouth, you're going to stick it out so I can feel it on your cheek. So protrude your tongue. Okay, check the strength. Then the other side. And I would ask you to please stick your tongue out. Okay, perfect. And I would also ask the patient to do a lingual sound. So just please say la.
La.
Perfect, that's it. I will ask the patient to please swallow. Do you have any pain when you swallow?
No.
No pain when she swallows, and I see that the throat moves evenly throughout as well. Okay, lastly, I'm going to be inspecting the neck. For the neck, I'm going to be looking at the skin, make sure that there's no discoloration, it's even, it's symmetrical, that the skin is intact. I will also check for the range of movement. So this, I will ask the patient to please tilt your head, look to the right. Okay, now look to the left, up, down. Okay, so her range of movement is intact. Do you feel any pain when you move your neck? Perfect. I would inspect the trachea, make sure that it's even. It's even throughout. I can palpate the carotid pulses here as well since I'm at the neck. So I would take 2 fingers. I will come here. It's +2, no bruit. Check on the other side. +2, no bruit. I will palpate the lymph nodes as well, so lightly be tapping. I shouldn't really feel any lymph nodes at all. If I do, then that's an abnormality. They're swollen. And if she has any pain, that would also be abnormal. Lastly, I would inspect and palpate the thyroid. So I will ask the patient to please turn like this. I will ask her to swallow. So the thyroid moves evenly up there, and it's not, I can feel it right here. It's intact, it's midline. Okay, so this is the physical assessment of the lungs. What I would first do is I would look at the general appearance of the skin, make sure there's no pallor, any cyanosis present. I will look at the shape, symmetry of the landmarks, the clavicles, make sure that the sternum and the clavicles are flat and immobile. I'm looking to see if there's any barrel chest or pigeon chest present as well, making sure that the breathing is even and unlabored. I'm looking for breathing that's 12 to 20 times per minute. I will also look at the lips, make sure there's no pursing, any cyanosis, pallor to there as well. As I note the lips, I'm also noting the breath. People that have diabetes or any sort of metabolic conditions, they usually have some sort of particular breath. Diabetes would be like a fruity breath. I will look at the nares, make sure there's no flaring, no cyanosis there either. And I will also look at the hands, make sure that the hands, they are both warm to touch, there's no cyanosis, no clubbing, no pallor to them as well. Okay, next I will move on to the palpation. First I will palpate the trachea. I will place my index finger at the suprasternal notch and move it down gently. I want to make sure that the trachea is midline. Next I will look at the chest expansion. So for this, I will place my hands on both sides of the chest where the stern xiphoid process is. I will ask the patient please take a deep breath, and I'll make sure that my hands are moving evenly in expansion. I will also palpate the skin, make sure that along the thoracic muscles, the rib cage, looking for any depressions, unusual movement, any crepitus, bulges, depression, any coarse vibrations. I will also make sure that the clavicles and then the sternum border are immobile and stationary. Next, I will do tactile fremitus. This is essentially looking at the vibration of the chest wall when the patient is speaking. So we'll ask them to say 99 as I place my palmar surfaces of my fingers with a firm light touch, comparing them simultaneously and symmetrically. So every time I place my hand, say 99.
99, 99, 99, 99.
Okay. Next, I will do percussion. For the percussion, I place my hand, my left hand flat, and then I will just tap the joint and my middle finger, and I will look for any dullness or resonance. And I'll be moving symmetrically side to side. Okay, next, if you could please turn around. For the posterior aspects, I will also look at the general aspect for any pallor, cyanosis, any bulges, any sort of lacerations, abnormalities, or any asymmetry to the back of the chest. I will run down my hand down the spinal process, and I'll make sure that it's midline and even. If it's not, then I will look for any sort of deviations like kyphosis, lordosis, or scoliosis. I will also palpate the scapula, make sure that all the muscles and the bones are even as well. Go to the lateral aspects. Next, I will also do tactile fremitus in the posterior portion of the chest. So again, I will ask the patient to say 99 as I move down symmetrically, palpating the posterior of the chest. So please say 99.
99, 99, 99, 99, 99.
Perfect. And then I would do percussion in the posterior portion of the chest as well. So again, I will place my hand flat and move it down, looking for any dullness, resonance. Okay. Next, since I did the percussion, I could also do the diaphragmatic excursion. For this, I will ask the patient to take a deep breath, and then as he holds the breath in, I will go down the spine and look for when it goes from resonance to dullness. So please take a deep breath. So once it becomes dull, I will mark that you can breathe normally now. I will mark the area, and then I will ask the patient to exhale all the air, and I will do the same thing. And then again, mark the area where it goes from resonance to dullness. So exhale. Okay, so then I would mark the area, and then I would measure what it is between the two markings, and it should be anywhere between 3 to 5 centimeters in length. The last portion of the lung assessment will be auscultation. So for this, I will ask the patient to please take a deep breath in through your mouth as I move my stethoscope side to side symmetrically. So I'll start in the posterior areas, and this is the position of the patient right now. Okay, deep breath. Okay, you can turn around. So as I do this, I'm going from side to side to compare one side to the other. I'm looking to hear clear sounds. If I hear any rhonchi or any crackles, that's a deviation. I'm using the diaphragm of my stethoscope. So I'm going to do the same thing in the front, okay? Also do the lateral aspects. Okay, and that concludes the respiratory assessment. For the auscultation portion of the cardiac assessment, I will go over to the right midclavicular, second intercostal space, and I would listen for the aortic valve. Then I would move over to the left side left midclavicular, and I would go to the second intercostal space for the pulmonary valve. Then I will go down to the third intercostal space, left midclavicular line for the Erb's point. Then I will go down to the fourth intercostal space, left midclavicular line to listen to the tricuspid valve, and to the fifth intercostal space, left midclavicular for the mitral valve. So for the cardio portion of the physical assessment, I would start off by having the patient usually sit up in the upright position. I will take a look at, take a general look at the skin, see for any pallor and bluish discoloration in the portion of the skin. I would also make sure that the weight is in proportion with the height of the patient. I will take a look at the eyes. I will see for any color, any lesions, any protrusion. At the lips as well, for the same thing that I look at the skin, any pallor, discoloration, any bluish tone, bluish so, poor circulation. Next, I will look at the extremities. I will look at the nail beds, look at the appearance of the general skin, look for any edema, feel for the temperature, look at the hair distribution. In order to do an inspection of the precardium, the patient has to lie down in a supine position. I would shine the light over to the apex point of the heart, and I would look for any pulsation and any heaves happening. In order to inspect the jugular vein, again, have the patient lie down supine. You would have the head of the bed elevated 45 degrees. I would shine a pen light to illustrate the veins of the neck and above the sternal angle, and then using a centimeter ruler, I will measure from the angle of Lewis, which is right over here, over to the highest point where the jugular vein is pulsating. I would add 5 centimeters to that measurement because the right atrium is usually 5 centimeters below the sternal angle border. For palpation, in order to palpate for the precardium, I would have the patient lie supine. I will palpate the areas of the chest wall that cover the heart, and I will put 2 fingers over to the apex portion, and I will feel for any heaving, lifts, or any thrills. For the palpation of the PMI, I will go over to the left midclavicular space, midclavicular fifth intercostal space with 2 fingers, and feel for the pulse, noting the location, the size, the intensity, the rate, and the regularity. For the carotid pulse, in the supine position that the patient is in, I would place my fingers gently on the neck, and I will feel for the pulse on one side at a time. For the 6 major arterial vessels, I will go along and note them out. And as I'm doing so, I will be noticing the presence, the equality, and the volume, grading them between a scale of 0 to +4, +2 being the normal grade. So in the inner portion of the elbow, this would be the brachial pulse. In the wrist area where the thumb is, this is the radial pulse. In the wrist area on the side of where the pinky is, this is the ulnar pulse. Behind the knee, in this portion right here, it would be the popliteal. In the top of the foot, it would be the dorsalis pedis, and I will feel palpate. And then in the inner ankle, this is where the posterior tibial would be. Again, for the upper and lower extremities, I would check for capillary refill. So this is when you pinch down, you may notice the blanchable, and it comes back to the normal color. It should be within less than 3 seconds that happens, and I will also do it to the lower extremities as well. For the lower extremities, I will note the hair distribution, note for any discoloration, touch for the temperature, see if there's any edema, whether it's trace edema, pitting edema, and if there's any thrombophlebitis happening on either one of the lower extremities. And that's what I would do for this